Good evening, everyone. Welcome to our webinar tonight. My name is Shirley, and I'm going to be your moderator this evening. Tonight's webinar is titled Implants and CBCT 101, Master the Basics. We are thrilled to have Dr. Stephen Vorholt, who is a diplomat of the American Board of Oral Implantology and a GP who focused solely on implant surgery. So welcome, Doctor. And before we get started, I'd like to go over quickly some housekeeping things. If you have a question, we ask you to please type it into the Q&A box and we will answer them via email. CE is not available for this webinar, and everyone who registered will be getting a link. Well, with that, welcome Dr. Vorholt again, and thank you for being with us. I'm going to pass it over to you now.
All right. Thank you so much, Shirley. All right, everybody. Welcome and thanks for tuning in for the webinar. And thank you, Henry Schein Academy, for hosting me as we take it back to the basics in implants and CBCT, implants and CBCT 101, mastering the basics. And so quickly, I'll introduce myself and then we'll go through kind of what our main points are for tonight's webinar. So we'll talk about myself, what I do, who I am, and how I practice dentistry. When it comes to CBCT, I talk to a lot of dentists about CT. So we're going to talk kind of about what dentists think they need when I first speak to a dentist who's looking into CBCT. And then we'll talk about what dentists actually need, something they should actually be focusing on. We'll dive into how I use my CBCT, which is the Acteon Prime, and AIS 3D, which is the software. And then at the very end, we'll have some resources. And then, like Shirley said, any questions can be sent to me and I will reach back out to you with any answers. So who am I? My name is Stephen Vorholt. I'm a general dentist who practices currently in California. I graduated from The Ohio State University in 2013, had a private scratch start there in Columbus, Ohio for almost 5 years. And then I had just felt an urge to get out of my shell and do more surgery. And so I moved to Arizona and took a position full-time with a company called Implant Pathway. And Implant Pathway is a training facility in Tempe, Arizona. We trained over 1,000 dentists in the 3 years that I was there. And I still go back roughly about once a month to help mentor dentists as they kind of pick up new surgical skills. So that's where I got most of my implant knowledge, was a crucible of implantology at Implant Pathway. And in that time, I also sat for, defended, and earned my diplomate in the American Board of Oral Implantology. And so now I solely focus since 2020 on dental implant therapy, from grafting, pre-implant placement to full restorations as well. For a year's time and ongoing, I also have a traveling business, mostly based out of the Phoenix metro area. And so I would show up to offices in the Phoenix area with all of these Milwaukee packouts with all of my, from implant motors to bone graft to every cassette under the sun and forceps and whatnot. My home office has 3D printers so that I could make guides. And we'll talk about guides briefly tonight in the second half of the webinar. So I could plan all of my cases using my Acteon software, even though I clearly didn't have a CBCT at the time because I was working out of my home office. But offices would send me their DICOM file sets, which is just the file set that comes out of a CT when you export it. I could load it into my software, plan the case, diagnose the case, 3D print a surgical guide if necessary, and then pack all this stuff up and go to each office. And so I still occasionally do that when I'm back in the Phoenix area for a select few of offices. But most currently, the past 9 months ago, my family and I moved to Santa Barbara, California, and opened Santa Barbara Dentures and Implants with Shared Practices Group. Shared Practice Group is a group of 35 dentures and implant clinics nationally. And this clinic is really more focused on the implants than the dentures, but we do a lot of all-on-fours, or what people call all-on-fours, and different implant restorations and stuff like that. And Santa Barbara is just an absolute beautiful place to live. And I'm just so thrilled and lucky that I get to practice there, which is great. So enough about me. Let's talk about you and what dentists think they need when they first get the itch to buy a CBCT. And any more CBCTs, we don't really talk about price in tonight's webinar, but I'll touch on it right now. The price of CBCTs has come way down. My first CBCT was in 2016 and it was $125,000. And now the CT that I use is closer to $55,000, brand new. And so as the competition has increased, as more and more dentists have incorporated this into their practice, thankfully the prices come way down, and now it's as much as a panoramic used to cost when you started practice. So anymore, a lot of offices I see are starting with CTs, which is great because I think it really opens a lot of doors for how much you can diagnose, how much you can see, and how much you can kind of impress and improve your patient's experience at the dentist office. And so let's talk about what dentists, when they're first looking at CT, think they need in a good CBCT. And so there's three things that I think most dentists, when they're first looking, they focus on these things. They think of the field of view, how much can they see? They think of the voxel, which is the pixel or the how tight the image is, like what's the smallest bit of data that they're able to slice and kind of and go through different slices on. And then they looked at rendering clarity. And so if you go to any major meeting, if you go to Thrive Live, in Vegas, and you walk the vendor hall, you're going to see a lot of CBCT companies, and they're going to wow you based on how clean things look in the 3D reconstruction of the patient, or they're going to tell you their voxel is all the way down to, some minuscule number, or that their field of view is, you can see the whole cranium. And those are the things that dentists, when they don't really know what a good CBCT does for them, that's the first things to look at, because that's the stuff that you can see on the screen, right? And so let's talk about some of those a little bit. When we talk about field of view, one thing we need to consider is how much do we want to see? How much do we need to see? And those two things aren't always the same. If you're just getting started and you maybe see yourself in the next 5 years placing dental implants, well, then you certainly want to be able to see both jaws in their entirety. If you take out wisdom teeth, you certainly want to be able to see far enough posteriorly to see the wisdom teeth. Maybe if you're going to be doing implants, you want to be able to see to the top of the sinus or the floor of the orbit. But do we need to see everything we see in this rendering here? Do we need to see any part of the cervical vertebra? Maybe you've been convinced that in order to bring airway into your practice, you need to be able to see the full airway. Well, that's one argument for having a higher field of view. Or maybe you're an oral surgeon or considering getting advanced training in stuff like zygomatic implants, in which case you would want to have a wider field of view. But for most part, most dentists, especially if they're not doing a lot of surgery, maybe a couple implants here and there, don't need, nor should they really want to be able to see well past the range of, of the tooth bearing regions of the jaw. And so when we look at different field of views, this has a general idea of what you can see in different field of views. Now, most machines are going to have a 5x5 as their smallest view. That's typically referred to as kind of the endo view, right? So patient comes in, patient of record comes in, I'm having pain all of a sudden in the upper left quadrant. So we take a quadrant scan of 5x5. The nice thing about 5x5, it also tends to be the tightest voxel. So because we're shooting such a small area, we can get really high detail. Some machines are going to cap out around 8x8 or 8x10 or something like that. And that's going to give you most of the tooth bearing regions of the jaw and the average person. If we want to see more than that, the picture that we saw that shows quite a bit more, 9x14, and these two numbers, because if we imagine this is just a cylinder, right? So one is the height and one is the diameter of the cylinder, as it were, is going to show us how much we want to see. Personally, as an implant surgeon, I want to see to the floor of the orbit so I can see the entirety of the sinus. I want to see back all the way at least to the pterygoids and kind of see the entire maxillary complex and the mandible. But I certainly don't care to see and want to see much of the cervical vertebra, because anything you do image, you are responsible for. And while we haven't heard of many case reports of people being, taken to court because they missed something that was completely non-dental related, it's not, a liability worth taking on if you have no intention of learning how to read cervical vertebra scans. And so field of view sounds really sexy to have this huge field of view. You can see the patient's entire cranium. You can see the frontal sinuses. For me personally, someone who uses CT day in and day out, I think 12x10, 12x14, 12x12 tells me everything I need to know for what I'm looking at. So the field of view I'm working with right now allows me to see this much. These are some cases I've done in the last month. I can see the majority of the mandible, almost all of the maxilla up into the sinus, and it gives me plenty of viewpoints to see, where I'm going to be placing these implants, avoid the nerves, avoid vital anatomy and such. And so this is the Acteon Prime 2. And so this is a 12 by 10 tall, 12 diameter in the cylinder. So it's just giving you an idea of kind of how much visualization you can get. Okay, point number 2, voxel. Everybody's worried about voxel. So we look at this image here showcasing the difference between a 0.2, 0.3, and 0.4. And I would say most modern machines, 0.2 is pretty much the standard. And you have to take into account that voxels get tighter as we get a smaller view. So like I said earlier, that 5x5 field of view is generally going to have a tighter voxel. For instance, in the Acteon Prime 2, if I were to do a 5x5 scan, I get to 0.0875 or 87.5 microns. Whereas if you do the full view, the 12 by 10, I'll get 0.2. And what this study showed is that anything 0.2 or better is great. Beyond that, there's not a big clinical difference in what you can and can't see. If it's worse than 0.2, if you're in the 0.3 and the 0.4, there are statistically different abilities for you to read things. And what this study was looking at was vertical defects in bone. And so something that's very difficult to see right around teeth. And so that's what they were looking at here. So 0.2 is going to be your maximum size. Anything better than 0.2 is great. But do double check that, because when you're going to buy a CT, they're going to tell you their best voxel. They're going to tell you their tight 5x5 field of view voxel. So make sure you also know what the voxel is when they go full field of view as far as the scanning goes. Okay. So what can we see at 0.2? We can see all sorts of anatomy at 0.2. So when we're drawing our panoramic curve in a CT, essentially what we're doing is we're drawing a 0.2 millimeter slice, and we're deciding kind of where that slice goes, what that focal trowel is. And so we can see things as clearly as the incisive branch of the inferior alveolar nerve, the neurovascular bundle. And why is that important? Well, in some surgeries, we're going to be down in this region if you're doing a lot of full arch, where you're doing all on fours, or you're doing overdentures and such, and you may actually come across this vessel. And some people will erroneously think that this might be a part of the mental nerve or an extension of the IA, and that's not the case. If you do traverse this and drill through it, you're not going to have any paresthesia or numbness in the chin. The only thing that innervates is actually the teeth in the anterior mandible, which if you're anywhere near this, there are very likely no teeth left in the anterior mandible. And so we're going to come across this occasionally during surgery. And here's a quick video of what's likely to happen. You're going to have not so much of a pulsile, but a very consistent bleed. And what do we do when it comes to having bleeds that are intrabony? Well, generally the thing you do with bleeding points is you put pressure. Right. So we want to put a tamponade, a pressure somehow to get to that vessel, crush the vessel, as it were. Problem is, this vessel, of course, is several millimeters down into the bone because we've hit it with an implant drill. So what do? Well, of course, you use what the best plug is for that particular bleed, which is the implant. And so it's an afterthought, but it's nice to see it on the CT before you get there. So, hey, I might have a bleed here. Maybe that's going to force me to not sequentially drill all 4 of my osteotomies, but go ahead and quickly finish that one so that I can get the bleeding to cease. And as you see there, once the implant's placed, of course, there's no more bleed. So that's the kind of thing we can see it at 0.2 without issue. Another example, this with my Acteon at a full field of view. So these are 0.2 millimeter slices, and I can see quite clearly this little notch. Most of us, before this comes across clinically, or before we learn about lateral sinus lifts, which is what we're looking at here, may completely ignore that notch, or it might be an afterthought, or not even recognize it. But what we're looking at is the intraosseous branch of the PSA as it runs through the maxillary lateral wall. And in this particular patient's case, she had some mini implants there that needed to be removed because they weren't holding on to much bone. And I could just see this little notch on the internal surface, or the medial surface of the lateral border of the maxilla. And sure enough, when we did the surgery, there with the big blue arrow, you can see the exact anatomy that we were seeing on that CT at a 0.2 voxel. So don't discount a 0.2 voxel. It's still very accurate. It's still very useful and clinically relevant. And it's enough to see big anatomy or small anatomy, like in this case here. What's the third thing that dentists look for or think they're looking for when they get into buying a CBCT is rendering clarity. You go through the vendor hall and you see all these really beautiful images that look like it's just a dried skull with teeth. And what is a rendering actually good for? What a rendering is software capabilities to take the images in an x-ray and compute them. And so it's computing power, it's software algorithms. It is helpful for large anatomy, like what we're looking at here. Where is the placement of the mental foramen? Where is the infraorbital foramen? Where generally is the floor of the nose and the zygomatic buttress and so on? It's not that helpful diagnostically. Like we might get some clues as to bone loss or large infections, but it's really helpful, I think, for like foramen and gross anatomy. So here we see the rare double foramen on the upper right and the even more rare triple foramen. And when you do run into these cases, you do have to treat every foramen with respect because there is some innervation that leads to the lip coming out of each of those. And so we can't just kind of cut the tiny ones and stick around with the big ones. But it's nice to be able to see that in some rendering clarity. So if CBCT software algorithms were not the limiting factor, because that's one big thing you'll get sold on is, well, look at our rendering. It's beautiful. Our software can really do some metal artifact reduction, and all of them can, but they're not diagnostic images. So they're really just for you to look at, showcase to a patient and understand that. There are things like inside my Acteon, there are many different profiles of different rendering settings that are simply taking Hounsfield units, which are density readings essentially, and saying, hey, if the Hounsfield unit is between 1000 and 1200, we're going to make it orange. If it's between this, we're going to make it white. And so there's a lot of different variability that you can get in these different presets that make things look better. For instance, one on the far left is considered the bone model. These are 4 different bone renderings, and there are others for airway. There's some that show off teeth. There's some that show off root canals better. So each software has a different amount of presets and so on. But what if we weren't so concerned about what a CBCT's rendering looked like? Because the price tag you're paying for that really sexy, cool rendering is maybe higher than you were bargaining for. So anymore now we have these. And what you're looking at here is actually an AI generated bone segmentation. There's a lot of companies that do this, but essentially it has nothing to do with software. What we've done is we've downloaded the DICOM data set, the actual raw data from the CT. And this, what you're looking at is the raw data from a Acteon Prime 2 in my office, upload it to the cloud to any of these AI rendering companies. And in a matter of minutes, 10 to 15 minutes, you can download the fully segmented models. This used to take 2 days and you'd have to pay a lab $100 or $200 to get these models back. And now we're talking $15 to $20 and 15 to 20 minutes, and we get these models back. And now I would much prefer to use this, which is actual data that is clinically relevant. You can even build guides off of this data and do bone-borne guides and everything else. You can 3D print these. So you can 3D print the patient's mandible, the patient's maxilla pre-surgically. You can do a lot of planning, even pre-drilling on them. And so anymore, the rendering is just fluff. So a lot of dentists get out and they think, I got to get a clean rendering because that's a software capability thing. I need a big field of view and I need a tight voxel. Most the field of view you need is probably 12 by 10 if you're doing normal dentistry and a handful of implants and surgery. The Voxel 0.2 or better is great, and almost every modern CT has that. And then when it comes to the rendering, regardless of how clean the rendering looks, if you're doing a surgery on it, you can have AI segment and get a very clean actual model that you can manipulate and print and use. And so those 3 things are really not as important anymore as they seem to be, but that's what the sales are focused at. And so when you talk to a salesperson, they're going to talk about those 3 things. So just important to understand what that is. So what do we actually need? How do we identify what dentists need from a CT? Here's what I think, in my opinion, you should actually focus on if you're looking at a CT. Software capabilities are number 1. You're going to be not using the electrons and the raw data. You're going to be using a piece of software. How can you use that software? What can you do in that software? How clean is that software? How easy, how user-friendly can your staff use the software? What capabilities come inside that software? Can you do model editing? Can you do guide design? Can you 3D print? These are more important than maybe a slightly better field of view or voxel that's coming out of that machine. Practice flow. How big is the machine? Where does it go in your office? Is it easy to use? Is it easy to get a 2D image and a 3D image? And then, of course, diagnostic quality is really the most important. What can you see in your image, and is it good enough for the dentistry that you want to complete in your office? If you're an endodontist, that might be different than if you're an implant surgeon or if you're a periodontist and so on. Okay. So let's talk about some of these things. There's lots of different types of software. For the most part, there are some CTs that come with just a viewer. You can diagnose and do some treatment planning on these softwares. Um, there's another in the middle here that's a native viewer. So it comes with your CTs, its own viewing software, but it also has internal guide design. So you can treatment plan and design guides, export things. Then there's a third party guide design, which is going to allow you to bring in CTs from other machines and manipulate them in there and so on. And so if you have one of the machines on the left, you're going to have to need one of the softwares on the far right in order to do both things. If you are in the middle here, where the Acteon and Sirona and Planmeca kind of live, they're kind of an all-in-one package. It's inclusive if you want to, pay for the upgrades in those software and unlock those options. Okay, so let's take a look at my Acteon workflow and how it works in my practice. So generally, the diagnosis happens based on the patient's medical history, dental history, chief complaint, et cetera, et cetera, et cetera, and all their conditions. And so now we're going to expose the CBCT. Okay. Now, when I was in private practice, had a CT, every new patient above the age of 18 got a CBCT. It took the place of a panoramic. It tells me so much more information. And you can decide if in your practice it makes sense to bill for that CBCT, whether you do medical billing, dental billing, fee for service, what have you. Personally, I never billed for a CBCT. The data I got and the impressions I got from my patients was more than worth the $200 or $300 I would try to get from it, especially if that meant doing it on less patients. So when we expose our CT, we're going to choose the field of view that is most relevant to the treatment planning we are trying to consider. If the patient is never had a CT in your office, I recommend getting the largest field of view you have, because even if a new patient comes in and says, I'm having pain on the upper left, I don't want to miss some big pathology down in the lower right. Or if that pain, we're going to lose, tooth number 13 and 14. If I could also see that, hey, we're also going to lose teeth numbers 2 to 5, maybe it's a different treatment plan than maybe if I just look at the upper left. So nonetheless, personally, if I'm going to get someone's first CBCT, it's going to be the largest field of view. We're going to then read the CT. We're going to talk briefly here about how I read CTs, but there's a lot of Henry Schein webinars that are fantastic. They go into depth about how to read the CT and the pathology and whatnot. So if you're interested in CTs, I highly recommend those webinars. So we're going to read the CBCT, not just the area we're interested in. If they come in because number 8 broke in a basketball accident, we're going to look at the whole volume of the CT, because medical legally we need to read the whole CT. And then we're certainly going to focus on that once we're done. If there's anything that you don't recognize or you're concerned about, you can send it to an oral maxillofacial radiologist for a more thorough reading. If we have an intraoral scan, which most of us do anymore, we're going to import and align the intraoral scan from that patient. That way we have a more accurate model to use if we're going to be manipulating it or making it a surgical guide and so on. And so using the rendering that's in the software can automatically align, bringing in someone's mandibular or maxillary model. And now we have an accurate soft and hard tissue model that is overlaid over the patient's bone. And that's what we can use to then, in this case, plan an implant. So this patient's missing number 19. We're going to do an anatomical wax up. This could be in your mind's eye. You could just look at this and say, hey, Steve, I'm a dentist. I looked at teeth long enough. The tooth should go between 18 and 20, and it should be about this wide. That's fine. In the software, you can also drop a little tooth in there, expand it, make it fit. And it just gives you a better idea of maybe where the emergence for your implant needs to be, the depth of your implant, and so on. So we're always planning with the final restoration in mind previous to putting the implant in, certainly. So what do we do after that? We're going to now take the STL overlay and understand that it's very important that the stitch or the overlay of our STL, which is our intraoral scan, was very accurate to the patient's 3D data, so that when we plan things in the 3D in the patient's bone, it relates one-to-one directly with the STL. Okay. We're going to confirm then that we have good health of bone buccal lingually. Okay, make sure our angle is good buccal lingually, and make sure we have good buccal plate thickness, lingual plate thickness. We're avoiding any anatomy, certainly. So in this case, the IA nerve is quite apical, which is nice. We're going to also confirm mesiodistally the implant. So we're looking at angles in all dimensions, right? In all 3 dimensions. So we're making sure the depth is good, the angle mesiodistally and buccolingually, and the positioning is good as well. And once we do that, it's quite simple to create a guide. So all of this done in the same software. Now we have a guide that is essentially a suck down night guard with windows cut out of it so that we can see things. And in the place where the implant's going to go, a very specific window is cut that allows a metal sleeve to go into, which will then allow, of course, our drills to go into. So after that's been made, we export that from our software. We now have a digital file that we can either send to a lab that we like, or if we have a 3D printer in the office, we can 3D print that straight in the office and then use it during our surgery. That's the general workflow for a simple implant guided case in the Acteon AIS 3D infrastructure. What about footprint? So size of a machine. If you're bringing a machine into a current practice, sometimes size is a big limiting factor. Personally, the practice I took over in Santa Barbara was a very small practice. It was previously a general practice. There was not even a panoramic x-ray in the space, so I had to knock down a small closet. And the Acteon unit is a wall-mounted unit, so it's quite small. It can fit anywhere a pano could fit, this can fit. That's not true with all CTs. Some of the CTs, like you see in the middle here, with the Axios, is a standing CT, so it takes up quite a bit more space. And then some of them that are quite large, like the iCat, actually has a sit down and takes up quite a bit more space, almost like the space of an operatory would. And so if you're in a current practice that you're going to be adding the CT to, and you don't have the space, like a large room, then you need to consider maybe the footprint and the ease of install. This unit takes about 3 hours to install. You have your general contractor add some additional backing to the wall there, so put it behind the drywall. Henry Schein comes in. This thing comes out of the box, gets mounted to a mounting plate, and it's operational within a couple of hours. It's pretty amazing. Make sure that in your practice flow, we're also not getting rid of 2-dimensional x-rays, of course. Every CT I know on the market also takes 2-dimensional x-rays. Some of them do it by changing the sensor, by flipping it around and running it around the patient one more time. The only one that I'm aware of is the Cavo OP3D that does them at the same time. And how they do that, I have no idea, but it does generate a 2D pan and a 3D CBCT at the same time. Most other machines, you have to select the button. It'll turn the sensor, reset, takes about a minute to reset, and take it on the same patient. Personally, in my office, I take a pano and a CT on every new patient because the pano is easier to go over the patient's treatment plan with and see things like caries and bone levels and whatnot. And because it's much easier for the computer to extrapolate a panoramic, I take the pano first, then we switch the sensor to the 3D, take the 3D because it takes half a minute to a minute for the computer to compress and completely render the 3D. So I don't want to do that first, have the patient waiting around for that to happen before the 2D. So just a little pro tip about how I do it. And then what we're really concerned about, right, which is diagnostic quality. Can we see what we need to diagnose to be safe? We have things like here, what we're looking at is the anterior loop of the mental foramen or the mental nerve, which sometimes is misconstrued as the offshoot. We already talked about the incisive branch, which is not the anterior loop. And one thing to consider when you're looking at the mental nerve and you're considering where to place implants is look at the luminal size of the vessel. And here you can see outlined in the dotted orange, that is the mental nerve, or the IA, as you call it, coming out of the mental foramen. And where you see it change, just mesial or anterior to that kind of bulge, that is the incisive branch of the nerve. Okay, you can see the lumen changes quite drastically into a smaller vessel, and that's where all the innervation for the lip is gone by that point. That's all exited the mandibles. But this area that's been shaded in red is what's considered the anterior loop. This is the portion that if you were to look at the mental nerve directly, like you're seeing here on the right, when we do a full thickness flap on the mandible, we're looking directly at the mental foramen. What is beyond that or more anterior mesial to that is this red shaded area. Important to know how much that is. And you can see that on a CT previous to doing any surgery. There's other things that you can find, like these retromolar canals and foramens, which is the kind of thing that I probably didn't see until someone pointed out. And now I can't help but see them all the time. Studies will quote anywhere from 5 to 75% of incidents, but these do have innervation. They do have arterioles. They can cause big bleeds. These can be some of the big bleeds in lower impacted wisdom teeth. Where sectioning teeth are pulling and we get a large bleed from the tooth socket. It could be a retromolar canal. And so you can find these on CTs when you're diagnosing your CT as well. And there's actually some innervation sometimes in these that innervates parts of the temporalis and buccinator muscles. So important to see these if they are there. Here's an example of one. It's just a little offshoot that kind of comes off, branches off the IA and shoots up generally in the retromolar area behind the tooth-bearing regions, but sometimes you'll see them. And here I've mapped it out because it's easy to miss when your eye naturally goes to this large IA canal. Now we can see, because I've mapped it out in the blue, where that retromolar canal is. And so if you're having trouble getting someone numb in the second molar region, it very well, if you look back at the CT, because, oh gosh, there is a secondary innervation there that maybe I need to put some septicane back there in the retromolar pad area, and that'll help. Some other neurovascular bundles, the incisive that does leave the mental and goes to the midline does exit the midline mandible on the posterior surface of the midline and then travels and connects to the lingual artery. And so it anastomoses with the sublingual and lingual arteries near the midline, and generally is at the level of the genotubercles, where all the muscles and tendons of the tongue attach. And so if you're doing this on a severely resorbed mandible and flapping, you may run into this. If you're doing a mandibular surgery and having to do quite a bit of alveoloplasty, you may run into this. And so it's important to see this on your CT, know how deep it is to the crest, so you know kind of generally if and when you're going to be nearing it, because this is not an arterial that you want to accidentally sever. It's a lot easier to stem bleeding that's intrabony because, like we talked about earlier, we just need some pressure. That could be an implant, it could be bone wax, it could be bone graft, it could be a number of things. Bone bleed or bleeds that are arterial in nature that are outside of the bone, like floor of mouth bleeds, lingual artery bleeds, those are much more severe and potentially life-threatening. And so we want to make sure that we have seen these ahead of time and are not surprised by it. But they are visible. And here's that same case after we've done some alveoloplasty, and you see we get quite close, this little tubercle here, and you can see this artery kind of running back from the mandible to underneath the tongue. And so it just kind of disappears in the floor of the mouth. Not something you want to necessarily accidentally nick, and then it rolls back under the tongue and causes a bleed. And so here we see what we did in this particular case is we tied it off with some silk sutures. And that way, if we did cut it, we wouldn't have a bleed. And the silk sutures, while they're non-resorbable in effect, after about 2 years, they will resorb. And so oral surgeons do use silk in deep tissues to get bleeding points if they need the knot to hold, because that's one thing silk does very well. So sometimes you'll see silk ligatures for these kind of things too. So pretty rare, but an interesting case nonetheless that you can see on a CBCT, so you're not taken by surprise. So let's talk about reading the CT. The first read we're going to do is called the scout plane. All CTs should open in this 4-panel view. It is a simply the 3 dimensions, right? So the coronal, the sagittal, and the axial, and then a 3D rendering. And so we can do a very quick read through the scout plane by sliding through. This takes usually less than a minute. And generally the most convenient reading for pathology is going to be the axial slice, because we can look at symmetry down the midline and see if things that kind of pop out. Okay. So the initial read, less than 90 seconds. We're going to quickly go over, first thing I'm going to do is line it up parallel to the maxillary hard palate and down the midline. That way I know that I'm generally going to be looking at things in the axial in this lower left screen, down the midline. And so we're looking for anatomy and asymmetries, like wild asymmetries. That's one main thing of path. Okay. So we're going to look at the axial. We're going to stop up and down at certain key points that we'll talk about. Then we're going to go from the front, like the chin to the throat. So we're looking at the upper right here. We're seeing the nasal cavity. We're seeing the sinuses. We're seeing the posterior tooth-bearing regions of the jaw, buccolingually. And then lastly, going right to left or left to right, we're going to get a really good view, once again, of the sinuses. We're going to get a good view of the anterior portions of the tooth-bearing regions of the jaw. So great for pathology, trauma, etc. And we'll get a really nice view of the midline as well. Lastly, we're going to look at the 3D rendering for gross anatomy, like we spoke about earlier. So foramen, tubercles, maybe some tori, undercuts, etc. Okay, so that's a very quick read. This is the read you do without the patient in the room. Hygienist or your assistant says, "Hey, doc, the CT is up to reread. You're still in your office. This is the read you do before you walk in the room, so you're not taken by surprise. You know what you're walking into." Okay. So we're going to slow it down and go through everything one more time. First thing I'm going to do is use the axial slices first because I want to look for first impressions. Generally, are there a lot of caries? Do we have periodontal disease? Are we missing a lot of teeth? Are we edentulous? What have you? We're going to stop and scan a little bit at each of these points. And so what I'm doing is I'm essentially scrolling up and down, cutting the face completely symmetrically because I lined everything up in the midline. And we're going to be looking at the sinus in the nasal region, and we're going to kind of go back and forth. Then we're going to go to the apices of the maxillary teeth, go back and forth, contact points in the mandibular teeth, apices in the mandibular teeth, and then the IA pathway mental foramen. So all of these areas are kind of the hot spots. This is where we're going to look for path. You're looking for path in the sinus and the nose. Generally, you're looking for apical pathology, caries, large caries, and then large caries again, apical pathology, and then the nerve pathway, right? So here's what we're looking for in the axial slice of this patient. As we scroll up and down, we see some polyps in the sinus. We see that the right side of the nasal passage is more blocked than the left. You can kind of see that's a little bit more less airway flow. We see some apical pathology there on the patient's left. We see a large defect on the patient's right. So here we're just scrolling through. Now we're seeing tori in the mandible. So, okay, there's some tori. There's some more apical pathology in the anterior incisor region. So this gives me a pretty quick, brief overview of pathology. I saw several apical abscesses. I saw some large defects from previous extractions. I saw some tori on the bottom. And I saw something going on in the nose where one side of the nose is more restricted than the other. We're going to see a lot of this again in these different slices. So now we're in the coronal slice, which is going to be the best view for the buccolingual dimensions of the back teeth, the view that we don't get in any two-dimensional x-rays, right? Great for looking at implant treatment planning. We're going to look at the nasal passage for congestion or patency. We're going to look at the sinus floor and the lateral and medial walls of the sinus and look for ostium patency, which is the superior medial posterior portion of the sinus where the sinus drains into the nose. And you can look, of course, at the mental foramen too. And so we'll take a look at this video and see what we see here. Starting from the nose going backwards, can't see much in the anterior, so we're going to get past that. Here's the mental foramen. Here, look at the nose again, the right side, our left. The right side of the nose, very congested. We're looking at the ostium, which is patent on both sides, and sinuses look nice and clear. And of course, we can also see the teeth in the posterior as well. Last thing we're going to look at as far as the DICOM x-ray is a sagittal slice, so the left to right slice. Okay, this is the best view to look at the buccolingual dimension of the anterior teeth for trauma, apical lesions, fractures, etc. And if you're planning immediate implants in the aesthetic zone, this is the view you need. We're going to see how far the sinus extends in the anterior region. Sometimes it goes all the way up to the lateral incisor, I've seen before. Generally, the first premolar is what you'd expect. We're going to look at the incisive foramen where the nasopalatine nerve canal is. And take a look at that. And this is where you'll see the airway. So at the mid-sagittal median, you can get a good view of the airway and the space back in the pharyngeal space as well. Okay, we get a bite wing view of the posterior teeth as well in this. So we'll quickly go through this view. So we're scrolling all the way to one side. We get a good view of the IA as it dives through the mandible. We start to see the teeth in the posterior from the lateral view, like you would in the bite wing. And then here in the anterior, we see the buccolingual dimension. There's the nasopalatine canal, and at the midline, we can stop and see the airway, epiglottis, and so on. We're going to continue on to the other side. There, we can see a nice apical abscess on that fractured root, and the sinus once more on that side. And so those are the kind of things we can see in the sagittal view and the things we should be looking for. Okay. Lastly, the 3D rendering, like we mentioned already, we're looking for gross anatomy, larger anatomical relationships. So we're looking for the mental foramen. We're looking for, in this case, we can see quite a bit of abfraction on this patient. See a large defect in the upper right where the previous extraction was. And if we flip them around, we'll even be able to see, at the top here, infraorbital foramen under the zygomatic buttress. If we're going to be doing an infraorbital block, for instance, floor of the nose, and then looking at them from the throat view, essentially, we can see there the mandibular tori, the greater palatine canals. If we're going to do a V2 block, for instance, and all that gross anatomy that we need to see. So that's a very quick rundown of how to do the initial read. Okay, we also are going to then establish a panoramic curve. Generally, I think it's best to have two different curves for each jaw because the jaws are shaped differently. A lot of CTs will try to lock you into one curve to view the whole CT. So you might have to go back and manually do it. In the Acteon software, it has you choose maxillary or mandibular. And so it's nice because the maxilla is a horseshoe shape. The mandible is generally not. It's a V or U shaped. So in the maxilla, We're going to do more of a horseshoe shape going between the pterygoids in the back. Maybe if you're doing pterygoid implants, you're going to incorporate the medial pterygoid as in part of your in the focal trowel, and then in the mandible, generally going to go just midway in the alveolus, in the alveolar bone, midway down the root. Okay. We can then change the thickness of this slice that's 0.2 or the voxel thickness into something that's more readily readable as a panoramic, which might be 10 or even 20 millimeters of focal trowel. There's a lot of different ways to view CTs. Once I get into my implant planning, I really appreciate this view where I get to see the panoramic curve, the 3D, and then the axial, the tangential, and the cross-sectional slice. And the beauty of the tangential curve is that this top right curve that we're looking at is going to show every portion of the jaw in that buccolingual dimension we care about when we're doing implant treatment planning, okay? Because we've drawn that panoramic curve, so the tangential curve is simply giving us a slice as we go along that curve that we already drew. It's very nice to have that, okay? The other beauty of the tangential curve is when you find a spot you want to maybe plan an implant at or do some pathology reading, we can also zoom in and then rotate this around. So if we're going to be looking at this tooth, we can see it from the lateral, we can see it from the medial, distal, posterior, etc. And this is even better for when you're planning an implant and you want to make sure your implant is in good bone in all dimensions, completely circumferentially around it. So these are the kind of things we should be looking at in a CT. If I know I blew through how to read the CT really fast. There was a lot of great webinars. Like I said, Heidi Kohlfarber has some great ones on Henry Schein. She's an oral maxillofacial radiologist. She takes her time. There's like a couple hour-long ones on there if you want to get more detailed into how to read these things, what to look for, lots of examples of pathology and whatnot. But these are the kind of things that I'm looking for in every read of a CT. And it just becomes second nature when you've done, many, many of them. Okay. So let's jump back into something like how I actually use my CBCT. And then at the end of this, we'll do two examples that I've recently done using guides and whatnot. So first thing I want to talk about is guided implant surgery. Now, this webinar is not about guided implant surgery, but it's about implants 101. And so we're going to talk about the more simple guides, the ones that do single implants. And these are the kind of parameters that you can lean on from a guide, right? We're going to get position. So the actual like bullseye point of entry into the crestal bone, we're going to get angulation. So, where is it leaning? Make sure it's parallel to the contact points of our future restoration. The depth, can we control the depth? That's part of the reason we use guides, right? And then can we control the width increasing drills, the actual placement of the implant, and then even at the far end, can we do the prosthetic as well? So if we kind of back up and look at some of the original devices that are analog positioning devices, and this is what I trained with, and when I started my implant journey, was I had some of these tools that just kind of find the midline for it, find the midpoint for you between two teeth. So for instance, the one on the bottom right, which is in the photo in the middle as well, you just wedge it between two teeth. It's got a hole in the middle, and you're going to put it between two teeth. Pretty simple stuff. More complicated ones like the one you see below that, and in the top right photo for edentulous spans that have multiple teeth, so two premolars or premolar and a molar and so on. So these used to be the positioning devices you would buy when you were first placing implants if you needed some help. I don't think anyone uses these anymore, thankfully, which is probably good. You also have something that could maybe help not just with position initially, but the angulation. So these analog surgical stents, I like to call them. Sometimes you'll see these posted on social media or in webinars, and they'll refer to these as surgical guides, which I think is a complete misnomer because these are not guiding anything. There's no relation between this stent and the CBCT bone volume. So while it's nice to have a wax up, that works great if you're doing a veneer case or a crown case. That does not work well in surgery where we also need to know where vital anatomy is and bone volume, but it's better than maybe nothing. So people will use these to make sure that when they do their drilling, based on their analog or more, surgical experience of looking at the bone volume in person, they make sure that it's also restorable in the sense that it's coming out generally in the central fossa of the future restoration. Okay. But guided surgery, this is not. This is simply a wax up stent. What about depth? There are burrs that help you just with depth. The one you're seeing the video of here is the BioHorizons 2.5 burrs. You can buy a set of them that have these depth stops like you see on the left of the screen that has different depth stops at each general length of burr for the BioHorizons system. You can buy universal kits like you see on the right that is a sleeve that actually will slip over whatever your implant drill kit is. So the case you have here, you pick, whatever length you want. It's basically going to shorten your drill to that length. And then when you hub out on the crestal bone, you can't go any further. So there are these devices, depth stop burrs and whatnot. And one of the first implant systems I placed was Camlog, and their kit had all of these different depth burrs. So depending on what width and depth you wanted, there was a different burr for that. And it would just kind of give one less variable you need to worry about when you're doing the surgery. We combine all three of these things, the position, the angulation, and the depth, into what's called a pilot guide. A pilot guide is simply a guide that only does the pilot drill. So generally it's a 2.0 millimeter drill. And so here, this is what I use probably most frequently as a pilot guide. There's a lot of advantages to a pilot guide, but here's some examples. We have, in this case, the pilot guide is also the full guide because the implant is so small in the lateral incisor area. It's a 3.0 implant. We only did one drill and then placed the implant. But a lot of times we'll also be using the pilot and then doing freehanding for the additional width increasing port. But it takes care of 3 of the 6 main things you're looking for in a fully guided system. And these are arguably the 3 most difficult to get right if you're doing a freehand, which is the initial position, the angulation, and the depth. All of those things are vital. And once you get that first osteotomy with the 2.0, those 3 things, increasing the width with tapered drills is honestly quite simple. The drills want to naturally follow the path of least resistance, which is the path that you put that initial 2.0 burr in. So taking probably 80-85% of the difficulty of implant placement in one drill with a pilot guide that either you make yourself and print in your office or you have a lab make or what have you, is a huge advantage to people in Implants 101. I think it's when someone is starting their implant journey, this is the one thing I tell them to do is get pilot guides because it still allows you the ability to feel freehanding the width increasing. So you still get a feel for the bone, the density, the thickness, and you can still manipulate the bone if you need to move things. So you're not going fully guided right away out of the box where you don't ever learn that tactile sensation, but you're also not completely, on your own with nothing holding your hand and putting things in the right spot. So some other advantages to it, there's no additional kit required. All you need to do is buy a handful, like 2 or 3 or 4 2.0 drills that have some sort of depth stop that can go into it. I use the BioHorizons one because you can just buy them one, piece by piece or like $100 each. You just buy the 2x17, 21, 24, and 28, and there's your whole guided kit because the rest of it, you're going to get out your normal implant kit and do your width increasing drills. When you buy a guided kit, a kit that is meant for fully guided everything, that kit ends up being several $1,000s sometimes. And so that's an expense. So this is inexpensive. Works great in limited spaces. If it's a tight space, all you need is a 2.0 drill. You don't need to put a large drill or implant through there. You can do it flapless or flap. The 2 cases I'll show you, one was flap, one was flapless. Quick design. And then one of the cases I'll show you was actually a sinus lift. And in a lot of vertical sinus lift approaches, the main goal is to get just shy of the sinus with your initial drill. And this tackles that for you straight away. One of the disadvantages, of course, there is some potential air downstream after you've widening the drills with your width increasing drills. And we can't place our implant through the guide because, of course, the guide is only 2 millimeters wide. So it's difficult for things like immediate implants and sloped ridges because that requires generally different bone manipulation techniques that aren't guided. Okay, so that's pilot guides. What about if we include the width increasing drills? So now you're doing what most people will refer to as guided surgery. And so now the guide sleeve is quite a bit larger. It's probably 5 or 6 millimeters diameter. And every drill in the kit can go through this, whether it's a keyed or keyless kit, doesn't matter. But essentially, we're taking the entirety of the drilling sequence and doing it through a guide. The con of that, of course, there's some space limitations. If there's 2 implants next to each other, the sleeves are larger than the implants, and sometimes the sleeves will interfere with each other. And so you have to maybe print 2 separate guides, or you have to convert to a pilot guide or something like that. Patients who can't open very wide, of course, that's true with any guided surgery in the posterior. And this becomes more expensive and does require the entire separate guided kit, which is great if you love your guided kit. It makes it very simple. There are some fantastic kits out there. But if you're just getting started, it's an additional expense, and you lose a little bit of that tactile feel as well. So some examples of that This is BioHorizons older guided system that was still keyed. And so a key is what you see here, this little green sleeve that's kind of additional piece that converts essentially this sleeve into a smaller hole. Um, but it allows you for very accurate drilling. And in this particular case, we also did some um, bone regeneration on the outside of the implants. So there's your final restoration after all was done, but they're placed clearly in a restoratively driven approach to be right in the middle of the future crowns. And so this final photo was actually digitally designed before the patient was ever touched for surgery. That's the key with a good implant surgery. Case in point here, if we want to go fully guided, so now we've added one more word to guided surgery, it's fully guided. All that means is the implant itself is also going through the guide so that we can now correct for the timing, which is the rotational position of the implant, the correct depth of the implant, and of course the angulation and everything else. So not only do the drills go through the guide, but now the guide stays on for the implant itself to be inserted into it as well. That's really nice if you're doing something like bridges or you have pre-milled prosthetics, or you want to make sure that your timing is correct because you're going to do an angled abutment of some sort as well. And so in this case here, we have an edentulous span that's quite wide. It's 4 teeth. We're going to be placing 3 implants to replace those 4 teeth because posterior maxilla, very soft bone. We want to over-engineer this to a point. So we've done a wax up ahead of time to make sure that we space the implants out correctly. And here's our guide based off the wax up of the future teeth. It's not a great wax up. It's not a perfect in occlusion wax up, but the important part is it gives you an idea of the spacing needed for 2 premolars and 2 molars because you don't want to just evenly space the implants out necessarily. So here's that surgery. The guide goes on to confirm the good seat of the guide. I still will take the guide off after the 2.0, take your PAs, trust but verify the guide, make sure you still like it. And then at the very end, the implants themselves go through the guide. That way you can control for final depth, angulation, and timing like we spoke about. So these are the implant carriers, guided carriers. Implants go in, everything's closed up. The only step we haven't talked about is the prosthetic. So if you've come this far, you've done all 5 of these things, the implant itself is placed exactly where you want, you can pre-make a prosthetic if you get really good at this and you can trust your guide to put the implant exactly where you said it was going to go with the exact rotation, depth, and everything, you can pre-make prosthetics. This case is a pre-printed prosthetic for a pickup prosthetic. And so in this example, I'll show you real quick. We had a premolar that was fully guided. We knew exactly where the implant was going to go. We knew the depth. And with that information, we could pre-make a little crown for that tooth. So here's the implant post-surgery, immediate post-surgery. We put a temporary cylinder on. Our little Maryland wing bridge, pontic, as it were, gets seated over, fits right over with no adjustments because the implant was planned. The lab knew exactly where it would be. So they had a hole pre-drilled out of that little pontic. It was quickly picked up with some flowable composite in the mouth, unscrewed, removed. The wings were sacrificed and cut off. And then that temporary occlusion was checked and it was placed in the mouth. And so very quickly by pre-making these kind of things, because you know exactly where everything's going to be, you've taken something from fully guided to fully guided with a prosthetic. And this goes so much deeper as well if you're talking about full arch stuff where they're pre-making a whole row of teeth and so on and so forth. But that gives you the general idea of what's possible based on how deep your guide goes and what parameters your guide is fixing. Let's go ahead and show you 2 examples that I just wrapped up this month. This example, a patient comes in, they just want 1 more molar on the upper right, even though they have space, certainly for 3, like they have on the lower right. But they want something to match the upper left because they feel like they're not chewing as well as they could be. So we measure the sinus floor, the panoramic, we get the CT as well. And the CT shows, hey, we have about 9 millimeters or so. Now, is an option to place a shorter than 9 millimeter implant, a 6 or 7.5? Of course, that's an option. I personally like to engage the sinus floor with a little bit of a bump, unless it's about 10 millimeters long. So I like to get 10 millimeters, 11 millimeter long implants in the maxilla whenever possible because of the softer bone and whatnot. So we've brought in the patient's IOS scan, the intraoral scan, the STL. That's the blue thing you see here that's overlaid on top of the CT. We've planned our implant to be just shy of the sinus by a millimeter intentionally, not going to finish the implant there, of course, but that's where we want our drill to stop. So our pilot drill is going to go to the bottom of my planned implant. which means I know I'll be exactly a millimeter from the sinus floor. And then, depending on what technique you prefer, casket, Versa, osteotome, whatever, you can complete your vertical crestal sinus lift and then place your implant freehand, which is exactly what we did here. So here we have our kind of rough outline wax up of our molar, making sure that our angle is good to restore a molar in that position. Okay, here's our pilot guide. So the only drill that's going to go through this is going to be a 2-0 pilot. Here you can see it in the mouth. The windows certainly are only cut out so that we can visualize the day of surgery, that things are seated fully, and that we have a nice intimate contact with the teeth. And so we can see that here. That guide is well seated and is well adapted to the teeth. So we do a small flap. You can see here with a little vertical in the back, just enough to expose what we want. The guide goes on. The guide itself can actually hold that flap back for you. We do our 2-0 drill, and then I don't have any pictures between the 2-0 and the final, but just increasing the width, in this case with a Versa lift. So it's an autogenous, using the patient's own bone to kind of densify and push the bone up into the sinus. The implant was placed. Now, personally, when I do a single implant, especially in the posterior, I will immediately take the final impression as well, because I don't like to waste my patient's time. So we put a scan abutment on, we get an internal scanner, we go ahead and we grab a final impression of our future implant crown. We send that to the lab. I wait about 3 weeks to make sure the patient's post-ops have gone smoothly and there's no, post-operative infections and whatnot. And then I order the crown roughly about a month after the surgery so that I have it ready for me at week 12 or 14 or whatever it is that we decide to restore it. Now, in this particular case, we buried the implant. We took this impression, we sutured everything closed with a cover screw and let it heal. And you can see, if you look real closely, you can just see with my mouse the little sinus bump that we have. It's not very radio dense, but there's a little sinus bump there from the Versa. And this is how the patient presents. So on the right, they come in, the gums have completely healed over. We make an incision to expose the cover screw. I unscrew the cover screw, screw in the crown, and the patient leaves. We suture the tissue to the crown and we allow the biologic width and the gums to heal to my ideal contour of the crown. The alternative used to be you would uncover the patient, put them in a healing abutment. The healing abutment still was not the shape of a crown. It was a circle. So you'd still generally, for a larger molar, have to get them numb and make an incision when you seat the final crown. So let's just skip 2 steps, have the crown made with ideal contours from the lab, and make the gums fit the crown. That's my general, and that does not work in the anterior. In the anterior, there's a much different protocol when it comes to provisionalizing and teasing the gums to be where you want them to be. But in the posterior, this is a great technique to get things quickly in and out of your practice, and for the patient to get a tooth with minimal interruption to their day. And worst case scenario, they come in, things have shifted, you have to adjust the bite, and maybe you get an impression that day. And if you had to redo it, which is very rare, honestly, in my experience. Okay, case number 2, implant number 30. So once again, patient just wants 1 tooth on the bottom. We do a pilot guide, lots of bone here. So some people would say, why do a guide? There's so much bone, and that's true. There's so much bone you can't really miss. You're not going to be out of the plate or in the nerve by any means, but I still want to place it in a place that's restoratively appropriate, not accidentally have it angling backwards or too distal from number 29 or what have you. It's so simple and inexpensive. It takes very little time, which you can get at, to make a pilot guide. So we're going to make a pilot guide. It's just going to put our hole in the right spot from the get-go. We'll make it wider. We'll put the implant in. So here's that case in a series of photos. Now this one was done completely flapless just for the initial drill. What's nice about that is the guide sits nicer because it's also resting on the tissue. The hole you make is not quite 2 millimeters. The drill might be that wide, but it slips through the tissue at quite a smaller hole. As you see here, it's less than 1 millimeter probably. And then our incision is simply cut right through the little punch that we've made. And then we can continue our drilling and widening. I personally don't like to tissue punch and take out a 4 or 5 millimeter disc of attached tissue, because that tissue I will never get back or will struggle to get back. But going through attached tissue with the 2-0 drill is totally reasonable. I lost 0.5 millimeter or 1 millimeter of tissue, and then we do a small envelope flap and place the implant. Once again, you see here, scan abutment, day of surgery, I'm scanning for the final. In this case, we put the patient in a healing abutment. So once again, circular healing abutment, not quite the shape of a molar. So at this delivery appointment, They were numbed. A small incision was made mid-crestal just to give a little bit of tissue, give some play, seat the final crown. And as they heal, they'll be a sore for a day or two. You see them back in a couple of weeks, the tissue will have filled in beautifully and they'll have a great contour on that crown. So those are the kind of surgeries that, I love when I get to do them because most of the surgeries I do are much more extensive or full mouth. But these little pebbles that fill the practice are a real big profit win because you're charging $5,000 for an implant. The total time it took you was the initial consult, the surgery, one quick follow-up, and then delivery of a crown at month 3. I mean, we're talking 2 hours for the whole case. And so when you get to that point, it's a very profitable thing to add to your practice and very predictable as well. So we're coming up on 59 minutes and 55 seconds. So we're killing it on time. I just want to give you one more thing for more resources. If you're looking for more information, looking into CT, Henry Schein has made this this kind of little ebook, as it were, with some of my experiences and my words. And it's called The Path to 100 Implants, my first year of CBCT, which was admittedly many years ago. But it's a great little ebook on how to integrate CBCT into your practice. So grab the QR code, get the secrets to how I implement it in my practice back in Ohio and have continued to, and will never go back from CBCT as well. All right. Thank you so much for joining me tonight, or if you're watching this on demand, thanks for watching this. I'll leave you with just these 3 words that I try to encourage in all of the dentists that I teach. Practice your passion. It will take you where you want to go. So thank you so much.
Thank you so much, Dr. Vorholt. That was really fascinating, and for walking us through the specificity of the guided tools. That is, we did record tonight's webinar, and the email with the recording will go out sometime in the next week. Again, please make sure you put your questions at the bottom of the screen, and we will get back to you via email. And we would also appreciate your feedback via our survey that's going to pop up on your screens shortly. Thank you again for joining us, and we look forward to seeing you on future webinars.